Greetings, everybody. I'm not sure how we're going to structure the questions, but I guess we'll see. Greetings, everybody. Anybody want to say hi? Dr. Kumar, hello. Darsh Trivedi, Hassan, hello. I guess you can hear me. Rose, you're there, right? Maybe not. Even Rose is deserting me. Oh my God, hello from Lagos, Nigeria. Welcome. Samuel, do you want to talk?
Hello, how are you?
Hey, Samuel, is your camera working?
Yes.
Let's see here. Yeah, I'll put my face on here too.
Hello, good afternoon.
Let me see, hold on.
Hello, good afternoon.
Here's mine. Oh, there you go, Samuel. How you doing?
Yeah, I'm all right. And yourself?
Good, good. How are things in Lagos?
Well, fine. So far, so good.
Okay, good.
Yeah.
Good. You're obviously a neurosurgeon or a resident?
No, I'm a neurosurgeon already.
Oh, okay. You've been here before, right?
Yes, yes. I do attend some of your.
Don't be afraid to let people get to know you.
Okay, okay.
Okay. No, don't be
Right,
shy. I
right.
know when I was in starting my career, I was very shy too.
Oh, okay.
But it's a different time now.
Oh, that's true.
Yeah, it's advantageous to be bold. I mean, to be
Sure.
bold and say, hey, my name's
Yeah.
John Bennett. And I'd like to
that's
meet you. I'd like to talk to you. I want to learn about this. So, hey,
Okay,
it can be a very valuable tool for you
sure.
to establish, friends.
Contact.
Yeah, contacts. You know.
I do.
People in medicine know, especially neurosurgery.
Yeah.
Neurosurgeons like to try. A lot of them like to travel for their education and their
That's true.
training. They
Yeah.
go to other countries. That's just part of the profession.
Yes, the process.
Yeah, like a fellowship, a month, 2 months, 3 months,
Yeah.
sometimes a year. So how
Well, I
about
do
you?
travel.
Are you planning on doing a fellowship or doing anything like that, or no?
Yes, yes, I'm planning on relocating to the UK by September.
Oh,
But
good. So you're
yeah,
applying for a fellowship now?
yes, yes. I
This,
trained in Ukraine. I returned home about 1.5 years ago, but the situation on ground isn't so favorable. So I
Mhm.
feel I want to, relocate.
Well,
And,
this is a good platform to get to know the people you're going to do your fellowship at.
yeah,
Get to know the people around the hospital and department.
okay,
It'd always be advantageous to be active in this platform,
okay,
so they know that, hey, this guy's an asset. You know, he's bringing more than just his body. He's bringing presence, and he's promoting our program.
Sure.
Because that's what you do. I mean, when you appear online, you're essentially promoting yourself as well as your hospital, as well as you know, what you do. But you know all that. I don't have to tell you that.
Yeah, that's fine.
Okay. Okay, we'll be back. I'm sorry. Go ahead.
I guess sometimes we all need reminder.
Yeah.
Yeah.
Okay. Okay. Well, I'll be back. Okay.
All right. Sure.
Yeah. Yeah, we start, let's see, it's 13 minutes. Yeah, 13 minutes. There you go, Abby. You can't see me, but I can see you.
Aha, where are you? You can't see me either. Video is off.
Yeah, the crowd has tamed down. They were quite unruly before.
Yeah. You could not manage that.
Well, I just throw some meat to the crowd. That calms everybody down.
Where are you hiding?
How you doing, Abby?
I'm okay.
Okay, so let's go over a second. Hold up. Get my camera here. Yeah, let's change the banner. So how are we going to work this out? I'll just introduce you, right? And you can coordinate Dr. Chopat. Huh?
You introduced Dr. Lokendra Singh. I think he'll moderate the session.
Oh, okay.
Okay, I'll be the backup.
Okay. You clean up.
What?
The cleanup hitter.
No, the backup.
Well, that's what in baseball they call the valuable player who comes to bat when the players are on base.
Okay.
It's called a cleanup.
Okay.
It's,
So
it's
yeah,
not
that's
meant. It's not meant in a derogatory fashion. It's a complimentary in baseball. It is. I don't know in cricket if they have this similar
no,
thing.
we don't, I don't think so.
Cricket, I don't understand at all.
I don't understand baseball.
Oh, really?
No, actually,
Well,
I
I
do.
guess
Cricket is
baseball
easy.
kind.
No, I understand it. Cricket is also easy, but
Yeah, baseball is kind of hard to understand, really. When
yeah.
But yeah, okay, Dr. Tripathi, right?
Yeah.
Manuals,
Dr. No, Dr.
Manjul's
Lokendra,
his name?
no, Lokendra Singh is the moderator. Tripathi is just
So
a guest
who's
speaker.
the moderator now?
Dr. Lokendra Singh.
Can you type that? I'm sorry, my hearing's not that great, Abby. Just type it in there.
Yeah, right. Got it?
Oh, okay, I don't know that one. Oh, Doc,
Yeah.
hold on. Is he on the banner?
Yeah, he's there on the banner.
Oh, okay.
He was the ex-president of the Neurological Society of India. So you can start
Okay.
with that. He's
Let me
from
write that
Nagpur.
down.
Yeah.
Lokendra, the head of the head of what?
President of the Neurological Society of India. Neurological NSI.
NSI. He's a president or head of the
Past
NSI.
president. Past president.
Oh, past president. Okay. Okay, introduce him and he moderates from there.
Yeah.
And a tool is going to give probably a presentation and well, it doesn't matter. He'll handle it.
Yeah, he'll handle it.
Excuse me. Samuel, you're there, right?
Yes, I am. I'm with you.
Okay, now we can do some networking while we're waiting. This is Avi Shah from India.
Okay.
This is
hello.
Sam's from
Hi.
Lagos, Nigeria.
Okay. Yes, so I'm Dr. Samuel Akinola. I trained in Ukraine, but currently practicing in Nigeria and Lagos. I
Okay.
run my own hospital. Yeah, and I'm happy to be attending this meeting.
Okay,
think
so
we
you in the Ukraine, Samuel?
Yes, I trained at the Institute of Neurosurgery in Ukraine.
Oh, okay, because we have a webcast tomorrow from the Ukraine.
I will attend that.
Good.
Yeah.
They are actually doing the Zoom. The Ukraine, I talked to them this morning. They
Yes,
are doing the Zoom and they're broadcasting it to the YouTube channel.
Yes, I think acoustic neuro. Yeah, okay. Yes, I will attend that tomorrow. I think it's on.
Yeah, you register. You know, the address is on my website. You're on my mailing list, right?
Yes, I am.
Yeah, you get all the information about registering with them, and I think they give you a Zoom link.
Yes,
so you're going to have to get in through that link.
Okay.
Not from me. But we do broadcast it from because they televise it to the YouTube channel.
Oh, okay.
And we were just but the person I talked to this morning from the Ukraine said that business is the usual at the neurosurgery ward.
Yes, it is.
They have elective surgery, and it's not just there's of course evidence of the war, but
Well, I
John?
think the capital is free now from the Russian occupiers. So I guess it's when I speak to my colleagues, everything is back to normal.
Okay. I'm sorry, I'm getting distracted here. Oh, there's Dr. Singh. Oh, there's Chandra.
Yes, John.
Hey, hello, Chandra, welcome. Oh, Dr. Singh, how are you doing?
Hi, how are you, John?
Dr. John Bennett, nice to meet you.
Nice to meet you, John.
Okay. I'll be introducing you first and you basically coordinate the show.
Please.
Okay, hello, good morning, Chandra.
Hi, John. Nice to see you again.
Nice to
And
see you.
welcome, Dr. Lokendra Singh and Dr. Abida.
Hello, sir.
Okay, we start in about 3 minutes. Is Atul's coming in, right, Abby?
He
Yes.
joined, I think, let him in the panel.
Oh, you're in here already? Yeah, I'm gonna make you co-host, Abby. You know how to admit people, right?
Yes, yes.
Okay, I'm gonna make you co-host. Oh, I'm sorry, Atul, I missed you there. Oh, yeah. There you go. I don't know if you hooked up there, Atul.
Hi, John.
The king has arrived.
How are you, my friend? Everything okay?
Everything's great.
Quite sunny here, John. Very
Yeah,
warm
looks-
and very hot in Mumbai. And in,
I
know,
heard
where-
it gets very hot in Mumbai, right?
I don't know how much is there in Nagpur. Lokendra, what is the temperature in Nagpur?
40, between 47 and 48.
Wow.
So let's enjoy the Miami
So
temperature.
we are nicely barbecued.
No, it's not hot yet in Miami yet, not yet. But it will get hot in about 2 months, a month or 2 months. Okay, Manjul, yeah, Manjul, I don't know. Manjul, can you talk?
Manjul?
You there, Manjul?
I think you need to admit him. He's there.
Oh, okay. I've been trying to admit him. I don't know what's going on here. Okay.
Am I audible to you, sir?
Yes, yes, Manjul.
Oh,
You
there
are
you go.
audible.
You got in
Can't see
finally.
you. You're not visible.
Thank you so much, sir. Good evening, sir. Good evening,
Good
everyone.
evening.
Good evening.
Good evening. Welcome. Okay, you ready, Manj? You ready, Lokendra?
Yeah.
Okay, hold on. We're going to start. Hold on, just give me a second. Okay, here we go. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good
Thank you
morning
very
from
much, friends.
good
Thank you,
morning
John.
from Miami. Hold on, Anjul. Good morning from Miami Beach. I'll introduce you, okay? Good morning from Miami Beach for Neurosurgical TV. We're honored with the program of the India Neurosurgery Grand Rounds. And the topic this week is arteriovenous malformations. And to host the proceedings is Dr. Lokendra Singh, past president of the Neurosurgical Society of India. Welcome, Lokendra.
Thank you very much, John, for this wonderful opportunity. My dear friends, today's topic is extremely important, as you can see. the cerebral arteriovenous malformation are enigma in themselves. There's so many methods of treatment, and still we don't know much about these because the percentage epidemiology-wise is so small that nobody can say that he's a great master of that art of treating the Avms. But today, in this Indian neurosurgical grand round, we have three pillars of our education, namely indomitable Dr. Atul Goyal, as we all know, then Dr. Chandra Dev Pujari, and he has been very, very active in all educative endeavors in India during COVID time. And then Archarian, probably he'll be joining us soon. I'm not very sure about that. So, my dear friends, I would like to invite my very dear friend and a wonderful researcher in the field of world neurosurgery, one of the largest publications in the world, as we all know. And he has a large experience about arteriovenous malformation. Obviously, CVJ remains his forte, but he has large experience in Avms also. May I invite Atul, please.
Thank you, my dear Lokender. And needless to say, I'm very happy and very proud and very honored to give this presentation on my very favorite subject of arteriovenous malformation. Arteriovenous malformation, as Dr. Lokendra has said, remains to be an enigma. I like to call arteriovenous malformation as the last chapter of neurosurgery. Last chapter because it is difficult. It is the most difficult of all neurosurgery. It is most anatomical of all neurosurgery. It is, and more than anything else, most philosophical of all neurosurgery. You have to be really experienced in every issue of neurosurgery to be able to handle arteriovenous malformations. So this is a small editorial I had written a long time ago. And in this editorial, I had written that there are two types of treatment for Avms. One is either do not just touch it, or if you have the courage, if you have the power, you remove it. And this is the treatment. Surgery is the treatment. Despite 1 century-old treatment, this still holds ground. The problem is, and the question is, that this treatment is difficult. And this treatment is not easy and can be dangerous and can be wrought with complications. And these complications can be devastating because we are not treating glioblastoma or any tumor where complication might just be acceptable to the patient. This is a benign issue. You create hemiplegia, that hemiplegia will last for a lifetime. So you just either do it, and if you are ready to do it properly, or you do not touch it. So my take on arteriovenous malformation is surgery is the treatment. And if you think you cannot operate, and if you think it is dangerous, and so don't operate, don't touch. So don't do anything at that time. Of course, in the interim, there has been treatments by radiosurgery, which Dr. Manjul will talk on. There have been some treatment options on endovascular interventional procedures that, I think Dr. Dev Pujari will discuss a little bit. So those are issues, but my thing is surgery is the treatment and surgery remains the treatment. Question is whether you can do it. So the main issue in Avm surgery selection is the nature of nidus of the Avm. It can be small on the motor strip, large in a relatively benign area, large in relatively benign area. But you see this Avm is a little bit different with aneurysm in the feeding channels, aneurysms in the nidus. So this is a high flow Avm. High flow Avm and low flow Avm, these are the two main issues in Avm surgery. This is a diffuse nidus. Obviously, you will not like to touch this. This is multiple nidus, and these nida are close to each other. Maybe there's one single nidus or whatever, but these kind of double nidus in close vicinity are relatively rare. So AVMs can be fed with large vessels, AVM can be fed with small vessels. The issue is when the larger the feeding vessels, the larger the draining veins, more is the blood supply to the AVM, higher is the flow in the AVM. So when you see large veins, multiple veins, deep veins, superficial veins, it is a high flow AVM and you have to be prepared. What matters during surgery is the nature of flow, and that is the most critical issue. Of course, location, of course, the type of draining vein, of course, the size. So I have a feeling that size matters. Larger the AVM, more difficult is the surgery. So I made my own simple classification rather than following any other classification. I have made this classification for me for surgery. So when I see an angiogram, I divide the AVM into 4 groups. One is easy for surgery, not for any other things. Difficult AVM, but relatively safe and can be possible. Very difficult. Maybe it is so difficult and very risky, but it is possible and can be thought about. And the 4th and the last grade is not safe or not possible. So this is my grading. As my experience grows, maybe very difficult becomes less difficult. My classification will be different for other surgeons. So every surgeon has his own way of dealing with. I call this classification as a dynamic classification. So as the AVM treatment has progressed over the years, the investigations have improved. You see, this is a large AVM. We do not know whether it is inside the ventricle or outside the ventricle. Obviously, inside the ventricle makes it more easier for surgery. Sorry for that. Outside the ventricle, it makes it more dangerous for surgery. So it is very important to know it is inside or outside. So we had made about 10 years ago, these kind of models for AVMs. These are elastic material. And these models obviously were not so great or not so good, but we had made attempt to get these models made. You see this good quality investigation can show you whether it is intraventricular or extraventricular. This DTI, of course, will show you whether the thing is inside the ventricle or outside the ventricle. So investigations have indeed improved. Few years ago, we presented this 3-dimensional model printing for AVMs, and I think there is beautiful models. You see this model, you can place the model during surgery in front of you. You can see the vessels, and you can have an idea as to where the lesion is. You can have an idea where to make the craniotomy. You can keep this model in the theater and mark the AVM and then do a craniotomy and then remove the AVM. Obviously, this is an help for the surgery and a great help during surgery. But surgery requires handling blood, surgery requires handling large vessels, small vessel, arteries, veins, and all those things. Models will help you, but what helps is your real attack on the AVM. This is another model for a very dangerous kind of AVM. You see the external carotid is also supplying the AVM, and you can know exactly how the AVM external carotid supply is there. Now, this is my index case. This girl comes with severe headache, young girl, and this is the AVM. And this is a very formidable kind of AVM. This is not a simple AVM. And the headache is also severe. You can see hair and this girl, the eyes, in a dangerous situation. Now the issue is, question is whether you want to remove it or not, whether you want to play around with embolization, whether you want to give any other kind of radiation treatment and all those things, which are possible, of course. But the question is whether you can remove it. And if you can remove it, whether you can move safely and whether you can come out safely. You cannot land in a situation where you start and you are not able to handle bleeding and you create a complication, you create a hemiplegia, you create a hematoma and reoperate and all those things, where that may not be acceptable at all for the patient and for the relative. So my take is that there is no other person that will decide whether this patient should be operated or not. It is the surgeon who will think that, yes, I can do it, and I can do it safely, and I can do it completely. There is no second chance in AVM surgery. There is no partial resection in AVM surgery. Complex surgery, whether I will be able to deal with the entire AVM, and means there is no here and there. You have to decide before operation whether you can remove it or not. And of course, this was removed completely, and this is a very happy patient with no headache after that. So you can cure, and that power is in your hand. Question is whether you have the confidence, that is one, whether you have the skill, whether you have the experience, and whether you can do it. There is no question of having ego and pseudo ego, because that ego will last before operation, and during operation, when the bleeding starts, all the ego will be dusted. So it is absolute perfection and complete understanding. That is why I call it philosophical surgery. This is another similar AVM. You see, it's a massive AVM, and this patient had come with only complaints of giddiness. And a youngish boy from a village, whether rich man, poor man, all those things will not matter. Matter is, yes, possible. So every AVM gives you an opportunity of good points and bad points. Like in this case, the anterior cerebral artery is huge, and anterior cerebral artery is predominantly supplying. So you come interhemispheric, get to the feeders early. So there are good points. And you have to prepare the operation absolutely meticulously and perfectly before operation. Like, I will come from here, then I will go here, then I will remove, then I will dissect, then I'll go to the middle cerebral artery. Large AVMs are always fed by multiple channels and also by feeding channels from the ventricle. That we must remember. All these huge AVMs have a contribution from ventricle, and this was removed, and you can see some smile on this patient who's cured completely. I did this about 15 years ago, has no problem at all. Another very eloquent and nice gentleman coming with only seizures as the problem, an IIT graduate. And the question was for seizures. You see, for seizures, you want to remove this and you can create issues. And you are not even sure when you remove the AVM, the seizures will be controlled or not. So this AVM presented with some good issues, some negative issues, and you have to plan and you have to prepare and you have to ultimately go for the resection and cure. And this is possible. No other treatment is possible or curative. So what I'm going to show you basically where whatever I have done and wherever I had complications, I will talk about those. So this is another AVM. You see, this AVM has some good points like interhemispheric large anterior cerebral artery feeders. Other thing is posterior cerebral artery feeders. And this is in a very complex area. You can imagine this is vein of Galen, straight sinus in the region, relationship with brainstem. And this is the AVM which is resected. I have done this quite a number of years ago. This patient has come with bleed. Now, patients with bleed, you must remember when the patient comes with bleed, it is a high flow AVM. When the patient comes with severe headache, it is a high flow AVM. When the patient has large vessels and feeding channel aneurysms and all, intranidal aneurysm, it is a high flow AVM. And what my style is, when I have such a patient, I go to the DSA room and see the angiogram being done and see the vessels coming, vessels going out, the flow, the rate of flow, and that forms very important criteria for me. And in this patient, you see this patient has a large PCA. And this, when there is a large PCA, I become happy because interhemispheric come and identify the PCA over the tentorium and then go for the feeding other vessels, come for the main vessel and then dissect it circumferentially. Of course, you have to have all kinds of tricks under your sleeve, and ultimately you have to come victorious, because if you don't come victorious with the AVM trophy and with the patient, you will not be happy ever. And you will regret taking decision. And what you have to do is you have to control bleeding during operation. Feeders with AVM with multiple channel feeders. This is a relatively straightforward AVM location. posterior parieto-occipital. But this AVM was very high flow. You see it's being fed by MCA, ACA, contralateral ACA, PCA. So this was one AVM which created jitters during the operation, but ultimately was resected and patient has been cured. So there is a possibility of complete cure, and complete cure means complete cure. This is not a tumor, and this recurrence rates are quite low. Where low means absent in this situation. This is another case come with bleed. You see the blood here and there, and this is the AVM. Now question is whether you see there are large intranidal aneurysms and things like that, and this is the AVM. And I will like to show you a little bit of video here, if possible. Now, in AVM, the craniotomy has to be large. The exposure has to be wide. You see, you can see this is the anterior circulation ACOM artery, and you have to identify bilateral, both optic nerves, both ACAs, both very wide exposure, and circumferentially come to grip the AVM. And it is difficult. You know, I'm showing you, maybe this is an edited version, but if you are, you have to rapidly go. You see the large vessels inside the AVM nidus. Large vessels will bleed, medium-sized vessels will bleed, small type vessels will bleed. More than one side bleeding will go at the same time, bleeding from here, bleeding from there. Now you have to identify which one to close, which one to attack, which is most important is identify normal from abnormal. You take one normal vessel, you just kill the person or make a deficit. So normal from abnormal, identify the feeder, coagulate the feeder, and cut the feeder. Then go on dissecting. So there are 3 steps: identification of normal from abnormal, coagulation, cut. That is the way you have to go on dissecting. And of course, this can create, ruckus in your own mind, ruckus in the operation theater. You will shout and you will howl if this bleeding will go. But what you have to do is control yourself, control the bleeding, control the entire scenario of the operation theater, and progress. It is difficult, but it is, if you ask me, after my 40 years of neurosurgery, which is one operation which gives me thrill and which gives me absolute pleasure. Pleasure means pleasure is all right, but during operation, it is not all pleasure, but it gives me great fun. And I like doing these AVM surgery because this is the surgery which I absolutely enjoy and I like to do. Large vessel bleeding, multiple areas bleeding. Most important is identify small vessels. Small vessels need not be coagulated. Small vessels lead you to a bigger vessel. Small vessels lead you to the mother vessel. And that is the area where you have to attack finally the mother vessel. Small vessel, you don't fiddle around with children. You go for the absolute origin of the AVM. And that is the only way you can resect the AVM completely. Complete resection means complete white field. There should be nothing red. And if there is something red, means there is a residual AVM. And that residual AVM has to be taken. If you don't take the residual AVM, it will bleed. So I don't believe in this normal pressure perfusion breakthrough theory and all those things. My concept is that if you have removed the AVM completely, no matter what, even huge AVMs, even massive AVMs, there will be no breakthrough bleeding and all. I don't believe in that. But this, has to be done beautifully and has to be done perfectly and has to be done circumferentially. Little bit I will edit here. And you see this AVM is ultimately being resected and dissected and removed. And this is the angiogram postoperatively. This is the AVM. And the person has been cured. There's no other way to cure these. Either leave it with symptoms. If the person has headache, leave him with headache. But headache is not a minor issue. So Sylvian Fisher AVMs are more dramatic looking because normal vessels and AVM can be mixed, and you can have a situation where I'll just show you a little bit of video here. And first, you have to identify normal from abnormal. Sometimes I use temporary clips to, if I'm not sure. to get the, and then I can dissect, and then I can, circumferentially, you see the huge veins. This is almost like a pile fistula and Avm complex combined. So this was a 2-in-1 kind of situation. So first identify in the sylvian fissure. Obviously, you cannot take a normal MCA vessel and create hemiplegia, identify normal from abnormal, and then go on resecting and resecting, bleeding. It will bleed. It has to be bleed. It is a vascular situation, but you have to have control on the Avm. You have to have control on your own self, and ultimately you have to resect this nasty kind of, and it is possible, and it is a curative kind of treatment. There is no question that this is the treatment. This is another huge Avm. Now you will say whether it, this patient also, I don't remember what symptoms, but this is a huge Avm. And there is, you see, this is like a pyramid, and you have the tip of the pyramid here near the anterior cerebral artery, and then you have to dissect and resect. There are some good points in this area. Majority is being fed by this area. And then this is the angiogram. This is the intraoperative situation. I don't want to show too much here, because Avm surgery cannot be shown in half a minute or 15 minutes, but it can be, it has to be experienced, it has to be enjoyed, it has to be done. And you have to have, when we take up neurosurgery, we take up challenges. It can be a difficult challenges, all right, but challenges has to be accepted and has to be undertaken with precaution, care, experience, because a patient is being treated, a human being is involved, and we are not allowed, we are not permitted. We will have certainly complications in our lifetime, but if we have, complications more than enough, then it is not permitted. This is another Avm which has been embolized. As many of you might know, I work in a department which has been very well known for embolization. So preoperative embolization, sometimes patient comes to embolization. I have to tell you that I am not terribly happy with preoperative embolization. I think I don't need preoperative embolization. I am happier without embolization, but if it is done, I don't mind it. So the question is whether I will like to do preoperative embolization or not. My answer is I don't like preoperative embolization. But if it is there, then it is there. And then you have to do this operation in a fascinating, beautiful fashion and attempt to cure. So what I'm doing is I'm trying to show you some Avms which have been resected. So this is another Avm with only giddiness, quite a dangerous looking Avm, quite a dramatic Avm, internal jugular vein, vena cava is large, high flow Avm. You see the vein, you see the feeders, and you see some good points of anterior cerebral artery, good point of posterior cerebral artery, come interhemispheric, get this feeder, and then resect. And it is possible, and it is beautifully possible. And I don't think I will like to show the video, but this has been removed beautifully. And this is after 2-3 years after surgery. Had some complaints here and there, but giddiness is gone and the patient is cured, and cured for life. This is another Avm which gave me jitters during operation, tentorium-based Avm, quite a high flow Avm, and this has been resected in a beautiful fashion. This Avm was referred to me by a very prominent politician of our country in the motor strip with only issue of convulsion. And you know what? This is one Avm which I, because very high profile person was involved and many people were involved, maybe I was taken over by that accolade, and I resected this Avm. I resected it beautifully, as you can see, but the problem is this patient developed hemiplegia after surgery. Hemiplegia is recovering to an extent, but still hemiplegic. So I am wondering that whether it was a good decision or not such a great decision to remove this motor strip Avm. You see in the motor strip in the region of very eloquent brain, but I removed it. I am still blame myself whether that surgery was necessary or not, but at least I think that the patient is cured and the patient is now walking, of course, not normally. This is another motor strip AVM. I have got a collection of beautiful motor strip AVM surgery. Earlier, I used to do AVM when the patient has come with motor strip AVM and hemiplegia. I used to operate after a period of time. This hemiplegia will normally recover, but now I operate early so that, you know, I get some support. Like if you operate on hemiplegic patient and who does not improve, then you may not be so much blamed. So I operate now in a rather early phase of post-operative. This is another motor strip AVM, which has been removed beautifully. And this is the post-operative angiogram. This is another motor strip. You see the dramatic. You can imagine the issues that can happen during operation. So you have to identify good points. You have to identify favorable for surgery. And you see some hand drop is there, but this child is absolutely all right. I have a feeling operating on children is much easier and much safer. Let us see what Dr. Devpujari will say. But this is an AVM essentially by the posterior cerebral artery. This is the model. And I had used contralateral approach for the, you know, in this patient and coming from here and removing this AVM. And this is the AVM and this is the angiogram. This is another AVM I recently did in Cooper Hospital in motor strip quite, but they have good points. You see, you do see the angiogram properly, slowly, one by one vessel, and which vessel will come and feed into it is, you know, looks quite dramatic, quite dangerous. But if you read this angiogram slowly, read the DSA film slowly, which vessel is the feeding vessel, which vessel comes to AVM, how it comes, how to attack this, I don't think it is as dangerous as it looks. It is in the motor speech area, but this was removed beautifully. This is another AVM which I have recently done. You see AVM, and this is the post-operative. You have to be absolutely, you know, as I mentioned, you cannot be here and there, and you have to be here or there. You cannot be here and there. This is another AVM which I have recently done. Quite a dramatic AVM, quite a high flow AVM, which was very fantastically removed. This is another high profile patient which I recently did, which was also very, very high flow AVM. The good thing was it is in temporal brain, but it was such a high flow AVM that during that I will probably lose this patient. This is one of the patients where I had done this with a contralateral approach. I do not recommend. I have described contralateral interhemispheric approach in 1996. That description, some people follow it. Even Michael Lawton talks about contralateral approach for AVM, but that approach was described first by me. I use this approach. I don't like to use it often. See, this is I have used contralateral approach, and this is the patient, and this is the post-operative. And this is the model. You can see how beautifully it shows the AVM. This is contralateral interhemispheric approach that I had described. This was letter to editor, but I had described this in 1996. This is another AVM in velum interpositum here. But the good thing is this posterior cerebral artery, anterior cerebral artery, location is all right, but possibility of resection is good. And you can see this AVM. This is another AVM which I had, you know, the patient had come with very multiple convulsions, and I removed this AVM in the left side. You see this like a, you cannot say I removed partially, I removed half, I removed stage, no partial. You have to remove it completely. And this was removed beautifully, but this patient developed Gersman syndrome and had calculation disturbance, and you know, a little bit here and there, but otherwise quite controlled with seizures and quite active in life and in his shop. But calculation is difficult, and making mistakes during calculation is his problem, and also naming. So that was, this is another in the speech area, only issue of convulsion, young girl, which I removed. This was also, you know, large vessels are good, but large vessels show high flow AVM. But There are some good issues in high flow AVM and large vessels. So this is another AVM, which is, you can see this AVM resected and this AVM postoperative angiogram. This AVM I did long time ago, and I created hemiplegia in this youngish boy, but this patient came to me several years ago with complete normal power, but this patient did develop hemiplegia after surgery. This was difficult, but completely cured. And when he came to me, he didn't even remember his hemiplegia. So patients developing postoperative worsening, if you have done a complete job, they will recover, and they will recover beautifully. Patient coming with bleed will recover. So this is another AVM has been resected. This is a posterior fossa. This is of course not posterior fossa. This is parieto-occipital. This is a relatively simpler AVM fed by PCA. PCA is my good friend, and come intrahemispheric. I don't like subtemporal or any other approach. Intrahemispheric, lateral approach, lumbar puncture, come near edge of the tentorium, get this feeder, and then work on the AVM. This is a mathematician I had done about 20 years ago, this AVM. See, I used to use multiple clips at that time. This patient, a mathematics teacher, still a mathematics teacher, and of course, completely asymptomatic. This is another AVM with some reversal of flow in the jugular vein. So if you can do it, you can cure it. The question is whether you can do it, because it can create a hassle, it can create a complication. There is a potential of uncontrollable bleeding, but there is a potential of curing, and that potential is in your hand. Intraventricular AVMs are relatively simpler. Choroid plexus, you get to the choroidal vessel, you get to the feeder, and you remove the AVM. This is temporal AVM, which has been removed. This is vela interpositum AVM, which has come with the bleed and difficult side, difficult approach, depth of the AVM, and this was removed beautifully. This is lenticulostriate feeders, and I had done this some years ago, and this is the angiogram, and the AVM was resected quite beautifully in this case. Now, this is the postoperative angiogram. Now, this AVM had come with a bleed and come with a drowsy situation. You know, I was enthusiastic, and I was, you know, at that time doing in and out these kind of AVMs, and I removed this AVM. Of course, this patient never recovered, but this patient, the AVM was removed, and AVM was dramatically during operation. I had huge problems, but it was removed beautifully, and this post-operative angiography was not possible. This is, I want to ask you whether this is easy or difficult. Some may say difficult, some may say easy, but it is not an AVM, it is a pile fistula. You get to this main feeder by endovascular route or by surgical route and just coagulate, finish this vessel, and the whole thing is gone. I was not knowing pile AV fistula at that time, and I did this by, you know, surgery, and I removed, and this the surgery is here going on. And actually, let me show you, if I can show you. It was some calcification and some AVM, and difficult and not difficult. You get to this feeding channel and you get this AVM. Unfortunately, I'm not able to show you. And this is the AVM which was removed. There is no need to remove the whole thing. You can just get to the feeding channels. So I have done several pile AV fistulas which have been removed, but the surgical strategy can be different by only getting to the feeding channel without doing. But putting glues and all those things may be useful, but glue can be sucked away into the sinus and can be a problem. And this is another pile AV fistula. This is another beautiful case. This is the post-operative. So I had reported some years ago pile AV fistula experience with 14 cases. Some AVMs are diffuse, and you have to put your hands up, say, I cannot remove it. This thalamic AVM, you can put your hand up and say, maybe I don't want to remove it. Now, sometimes I have a feeling that this AVM could have been resected, but this patient was lost to my treatment. This is another AVM. Sometimes I feel that brainstem AVMs, of course, can be quite dangerous. This AVM is another huge issue which I have not touched. This is another one. This is diffuse. I have not touched brainstem, going inside. Maybe I could have done this, but I have not touched at that time. So in preoperative embolization has a questionable role in AVM treatment. Whether it helps in AVM surgery, I'm not sure. I don't think it makes a difficult AVM easy. Partial embolization followed by no surgery may have negative influence in the overall bleeding rate. But, you know, I have got a little bit thought whether when I say to an AVM, I cannot operate, maybe little bit embolization of some intranidal aneurysms and may help the headache. Some feeding vessel embolization may help the headache and things like that. So there may be role for me in that kind of situation, and also has potential of various complications like this one. They were doing embolization, they got a bleed, and then I got an emergency situation where I removed this AVM with the clot. This was another one where this embolization was done on a multiple time, and this patient bled, and then so there can be, I removed it, but this patient never survived. So thank you very much, my dear. I want to give you a gist of AVM treatment and what happened to me and how it went on in my experience. Difficult situation, dangerous situation, but a wonderful surgery. We should, as neurosurgeon, should not leave this avenue for any other option. Thank you very much, Lokender and my dear friends.
Thank you, Atul. Are questions asked there? I'm not very sure.
But if questions, maybe we can think about answering them later, Lokender, you think?
Yeah, okay, that's fine. Fair enough. May I now hand over baton to Manjul, please?
Thank you so much, sir. Thank you. Am I audible to all?
Yeah.
Okay. Sir, let me just start it. So I'm sincerely thankful to Professor Goel, Dr. Abida, Professor Loken Singh sir, and Professor John for giving me this wonderful opportunity to speak again. So I'm going to speak on the role of gamma knife radiosurgery in the management of intracranial arteriovenous malformation. What is the current level of evidence? What we can do? What we can experiment on? So these are my disclaimers, and this talk is actually on my experience of treating nearly around 720 patients of Avm over the course of last 1 decade. And this is not the first time we are engaging on this discussion, which is a better knife. And the discussions have been as dynamic as the Avm itself. Nowadays, whenever a patient comes to you with a diagnosis of Avm, usually you are the third person from whom he's getting an opinion. And he comes utterly confused because of the variety of the opinions. Some people say that you shouldn't do anything at all, do not touch it. Some ask them to get it operated as soon as possible. Some tell that it should be embolized, you shouldn't ask the surgeons to fiddle with it. And some tell them to go for the gamma knife. Now the patient gets absolutely confused in this era of internet, whether I should do something or not. In that case, are we definitely wise and competent enough to answer each and every question of these patients? And are we medico-legally secure in giving that in writing? And the big question after Aruba happened, what is better, the disease or the treatment? Only when the treatment is actually better than the disease, you are allowed to intervene on that particular patient. Looking at the demographics, a lot has been stated. I would just tell that approximately half of the patients with the Avm may suffer ICS during their lifetime. And nearly 38% of these Avms are complex Avms. These are not Spreadsum Martin grade 1 or 2 Avm. These patients are actually the difficult patient for every treatment modality, as Sir just told, that for the complex Avms, it becomes a different ball game altogether. There is a very varied opinion about the natural history of Avm. Nobody is sure. In the patients who have already bled, the chances of major bleeds are 6% per year, and the mortality is 1% per year. But this annual hemorrhage risk represents a single element of the Avm natural history that needs to be compounded with the prospective risk of the headache, neurological disorders, seizures, psychological burdens, and the ischemic events which may happen in that patient's lifetime. So you cannot treat a 17 years with that similar angio architecture Avm, a 70-year person. You have to take the consideration of the age, angio architecture, presentation. and then you decide each AVM on an individual basis. This was a very famous study, Aruba, which was not an intention to treat study. And it created a lot of controversy. This was a perfect example of a badly designed study. And this interpreted that the medical management alone is superior to any kind of intervention therapy for an AVM, because the complications were mentioned to be too high. It was a flawed study with an insufficient follow-up period and the insufficient representation of the treatment modalities. As far as radiosurgery and gamma knife is concerned, there is no information on the obliteration rates. The results were on the short-term basis only, because the follow-up was only for the 33 months. It had an erroneously high complication rate that we usually routinely observe. Nearly 68% of these AVMs were of Spitz-Martin grade 1 and 2 only, and it had a poor representation of the other treatment modalities like radiotherapy and embolization. So as far as radiosurgery and Aruba are concerned, it has a flawed result. And that shouldn't be interpreted in the light of radiosurgery, because radiosurgery has a latency period of 3 years. The treatment is done in 1 day, but the effect takes nearly around 3 years to happen. So if you evaluate the result before the completion of the latency period, the results are going to be poorer. So the Aruba only serves to emphasize the obvious point that SRS may not be beneficial prior to the end of the latency period, and it does not add to our knowledge about SRS, and it cannot be used to counsel the patients about SRS. Once it got published, there have been multiple studies on the Aruba eligible patients and the role of the stereotactic radiosurgery in that. And this was a very good study published by the Losford group, which had 509 patients. And they found these patients with the Spitz-Martin grade 1 to 4. They found an AVM obliteration of 74% in a follow-up period of nearly around 86 months. And among these patients, 4% had a mortality, and the radiation-induced changes happened permanently in around 3% patients. But it came with a good obliteration rate of 75% in grade 1 to 4 AVMs. When we say that an AVM has an annual risk of hemorrhage of 4%, it's actually a false sense of security, because the bleed rate ranges from 0.9% to 34%, and that is dependent on the AVM angio architecture. How is the venous drainage, whether it's superficial or deep? How many are the draining channels? Is there any other high-risk factors like intranidal aneurysm or fistula? And what is the age of the patient? So you calculate all that. And in that, you find that different AVMs have a different bleed rate. You cannot just say that it is 4%, and that gives a false sense of security to the patient. I couldn't mention all classification schemes. If you just look from 1977 to 2002, these were the various classification schemes for various treatment modalities. And if any disease is having so many classification schemes, then definitely we are not sure about the exact treatment of the disease. Even if you look at the surgical schemes, there were 12 grades and 12 Lawton-Young classification scores. So there were 144 variants of the AVMs in literature. So no two AVMs are actually same. We just heard Sir's classification scheme. I find it the most simple and the most difficult classification scheme to follow, because it is a dynamic square. It's a dynamic classification scheme for a dynamic disease. You can follow it only if you are Atul Goyal, sir. Otherwise, it becomes a difficult one, because this is a surgical classification scheme and it depends on the competence of that particular surgeon. So I find it extremely difficult to follow as far as myself is concerned. When are we justified in treating an AVM, especially in the times of Aruba? If it has bled, that's a definite indication. But other indications are like steel phenomena, intractable headache, progressive neurological deterioration, and high-risk factors like aneurysm and fistula, which have actually bled in those patients. So in those patients, you are justified in treating. As Sir rightly told, it's a typical neurosurgical disorder. It's an all or none phenomena. You either have an AVM or you do not have an AVM at all. Because once you do not have an AVM, which is actually the goal of your treatment, you are cured from the bleed, chances of bleed. There is usually a good seizure control. You do not need any drug. And you are secure, you are psychologically secure that there is nothing bomb sitting inside your head which may rupture at any point of time, and you enjoy a good quality of life. Once you give gamma knife radiosurgery or SRS, how does it get obliterated? It's an obliteration from inside, and there is an inflammatory reaction from the outside, because it causes the damage to the endothelial cells. which causes the progressive thickening of the intimal layers with the smooth muscle proliferation and the gradual obliteration of the nidus. So it takes a period of around 2 to 3 years when it gets completely obliterated in a graded fashion. The obliteration is a time-dependent and a dose-dependent phenomenon. Once you irradiate, you need to actually wait for some time. If you give a good dose of somewhere around 22 to 24 gray, the chances of obliteration are pretty high, but there is a latency period of around 3 years. After 3 years, it's a very good obliteration. How much would it get obliterated? That is actually dependent on your nidus volume, the location of the nidus. A good dose is needed with a good more than 97 to 98% coverage. And the prior embolization is actually a negative prognostic factor for the radiosurgical outcome. You need to evaluate the outcome at the end of 3 years, and this is the literature summary which shows that if you consider all AVMs, the complete obliteration is 70 to 75%. For grade 1, 2, it's 90 to 100%. For deep-seated, it's 68 to 70. And the grade 4 and 5, with the hypofractionation and the dose fractionation regimes, volume fractionation regimes, it's 30 to 40%. If you give a higher dose, more than 22 gray, your chances of obliteration are nearly in the range of 98 to 100%. And that's actually on a personal experience also. When you irradiate an AVM with gamma knife, it's a very focused radiation only to the nidus, sparing the surrounding brain parenchyma. But giving such a high dose, you may expose the patient to the risk of complications. So you need to strike a balance between the AVM obliteration, minimizing the chances of complications. And for that, you need to follow the 12 gray rule, so that your brain do not, more than 10 cc of the brain is not exposed to 12 gray radiation. It is also dependent on the location of AVM. The AVMs which are superficial, not in the thalamus, basal ganglia, or in the brainstem, the chances of getting a complication are slightly higher if the nidus is in the deep location compared to the ones which are in the superficial locations. The factors which are responsible for the poor radiosurgical outcome, the first and the foremost factor is actually the targeting error. If you are not able to identify your nidus, if you are not able to identify the draining vein, the feeding artery, and sparing those ones from the nidus, you are bound to have a poor outcome. As Professor Lars Lexell rightly told, a fool with a tool is still a fool. So even with the gamma knife or any kind of a surgical tool, you need to identify your target properly, and then you bombard it with the radiosurgery. If it is a complex AVM, large AVM, and you are not giving sufficient dose, then there are chances that you may fail. And it needs a multidisciplinary approach. You need to evaluate the DSA properly. As Sir told that he goes to the DSA room before attacking any nidus, in the same way, I need to go to the DSA room for the exact definition of nidus, to better identification of the draining vein, to rule out the other associated anomalies like aneurysm, fistulous connections. Sometimes you are not able to identify whether it's a nidus or the proliferative angiopathy in a diffuse nidus. So you combine the images of the MRI and DSA, and then you pinpoint your nidus, and then you bombard over it. There are several myths about the radiosurgery, and we are going to come on it gradually. The site and size of an AVM dictates the risk of hemorrhage. Actually, this is a very controversial statement, and we are not sure about this in the literature, whether a small AVM ruptures more or the larger AVM ruptures more. But as far as radiosurgery are concerned, there are only some factors which should be counted at the high risk. The deep venous drainage is the negative prognostic factor, single venous drainage, intranidal aneurysm, and the high flow fistulous connections. These are the high risk factors which can lead to the bleed in these AVMs. The biggest surgical problem with the deep located AVMs, I'm not talking about the superficial ones. They are good for any treatment modality, and the best option for them remains the microsurgical resection. You remove it elegantly, safely, without creating a deficit. You are secure for the life. But the some ones which are situated deep inside, the presence of the deep white medullary feeders becomes a trouble for them. And as such says, never try to coagulate the deep medullary feeder, follow it in the depth, and it takes you to the mother vessel. If you do not go to the mother vessel, it would bleed, and you would have a large hematoma in the postoperative period. But at the same time, this is technically difficult, because once you are going through the deep white medullary feeders, you have a risk of injury to the white metal, and that white metal injury results in the neurological deficit. That's why even the large groups like the Lawton group, they recommend gamma knife in these patients, and they put surgery on a backside. With the course of time, our armamentarium has become better. We have better bipolars, we have neuronavigation, all those things. But does it really always translate into a better surgical result? That's really a questionable. And this is very operator dependent, very surgeon dependent phenomena. A deep feeder taking from the lenticular arteries, from the basilar perforators, they are a universal surgical problem. And in those cases, the safest and the effective treatment modality happens to be the gamma knife surgery. Even the endovascular should be discouraged in those patients because there are chances of some blue percolating somewhere, and then inadvertent occlusion of the perforators resulting into the neurological deficit. The biggest argument against gamma knife or any SRS happens is that AVM may bleed in the interval period, in that latency period of 3 years before that it gets completely obliterated, it may bleed. Yes, this is a risk factor, but if you compare to the natural history, you find that in this interval period, there is a 54% reduction in the risk of the rebleed in that period of time. So you do not find that same 4% or 5% annual bleed rate. It reduces to 2%, 1%. In my personal experience, I had 8 cases in the 10 years, 2 needed surgery, and 1 patient had a massive bleed and he died. The eloquence is a reason to withhold surgery in endovascular because these are very complex AVMs. And this is the reason to suggest gamma knife. Surgery is usually not recommended and gamma knife is recommended in these patients. I am in completely sync with Goel sir about embolization. I am personally against embolization in most of my cases. And so is the humans. The definite treatment options for patients diagnosed with intracranial AVMs are either your knife or gamma knife. Because the embolization is frequently performed in conjunction with other surgical resection, but is rarely curative in itself. Why am I personally against it? Because embolization in complex AVMs is rarely a complete embolization. They cause a patchy embolization, which makes the nidus definition difficult. They take multiple sittings, it comes at a higher cost. Most of the times it's a non-sectorial embolization, and in the patients who are prior embolized, the chances of radiosurgical cure are also less. And they come at a cost of the rapid recanalization over the next few years. When do I take their help? When there is a ruptured intranidal aneurysm or there is a fistula. What I usually require from my embolization colleagues for the large volume AVMs where I want to sector it, a sectorial embolization and the treatment of the rest with the high dose or perfect dose radiosurgery. But what I usually get is a very rough, patchy work because they come with the multiple feeders from the periphery. They just embolize some part here, some part there. And it doesn't help me at all because then I need to treat the whole 3D Angio architecture again. So the results are actually poor with the combined modalities. The flow reduction for radiosurgery is not of any benefit. That might be of benefit for the surgery, but as far as the radiosurgery is concerned, the flow reduction without volume reduction with the embolization is not going to be any help for me because that makes the nidus definition difficult and it doesn't result in a good neurosurgical outcome, radiosurgical outcome. This patient, sometimes I do take help of embolization, guys. Like this patient had a high flow fistula inside it. We took care of that fistula and treated the rest with the gamma knife radiosurgery. And this is the follow-up DSA at the end of 3 years. And there is a complete AVM obliteration. Combining endovascular approaches to radiosurgery are actually adding their respective complications rather than their individual therapeutic intent. And this has been repeatedly proven in the literature, and the difference is pretty huge, 70% versus 47%, 76% versus 26%. So I'm not very much pro for the embolization. Apart from it, embolic agents have radioprotectant values. So once you embolize, the effect of the radiation also gets dampened. A mere presence of an aneurysm is actually not a prerequisite for embolization. If it is a ruptured intranidal aneurysm, then you may go with an embolization for that particular aneurysm, and the rest of the AVM should be treated with the radiosurgery. Presence of an AVM, an intranidal aneurysm, an unruptured aneurysm is not an absolute indication for embolization because these are usually flow-related aneurysm and they're related to the AVM. Once you obliterate the AVM, these aneurysm collapse on its own. You do not need to follow this. Like this patient had a flow-related aneurysm with an AVM. It was an unruptured one. We just treated the AVM, and in the follow-up, there is a complete obliteration of nidus and the complete collapse of the aneurysm. You do not need to just jump over it. A diffuse nidus is a bigger problem because none wants to intervene. Sometimes there's an angiopathic changes also. In all these cases, GKRS is actually a better treatment modality. Still, there are some confusions about the nidus definition, but the results are better than comparison to the surgery and the embolization. If we go for the low-grade AVMs, I prefer microsurgical resection. I myself go for surgery in these patients, operate on these ones because that's the complete cure once and for all. But in patients who are surgical averse patients who do not want to undergo surgery, the gamma knife radiosurgery gives equitable results to the grade 1 to 2 AVM. The problem happens with the complex AVMs. When I say the complex AVMs, these are the grade 3 AVMs and beyond. Whether to treat or not to treat, and to treat, to how to treat, because they come with various permutations and combinations, and their angio architecture needs to be evaluated on each and individual basis. The key determinants of outcome in these patients in any AVM is actually the high dose and the size of the AVM nidus. Most of these complex AVMs are large volume AVMs. In those cases, I either go with the dose fractionation or the volume fractionation. Ideally, for any gamma knife radiosurgery, the target should be less than 10 cc in size, because in that case, you can give a very robust high dose of radiation, and that ensures the complete nidus obliteration. When the nidus becomes large in size, you need to downstage it. Either you can do it with the dose fractionation, or you can take care of some part with the embolization, and then you can treat the rest with the volume fractionation. So Professor Kanchan Mukherjee, who was my mentor, actually, he championed the dose fractionation gamma knife radiosurgery even before the introduction of the frameless osteotactic radiosurgery. And we find promising results with the dose and the volume fractionation. Like these patients with the deep-seated AVMs, large volume AVMs, it was a 35 cc AVM treated with a dose fractionation in 3 fractions with an interfraction interval of 24 hours in 3 days. And this got a complete obliteration by the end of 3 days. Another AVM, large AVM at treatment, he was treated in 2 fractions with a complete nidus obliteration. This we recently done 3 years ago, a complex AVM treated with 9 gray in the 3 fractions, and a very small nidus is left, and probably this is the 1-year follow-up DSA, and I think by the end of next year, this would be completely obliterated. A volume fractionation, it's something like killing the Jarasandh. Jarasandh is a Hindu, it was a Hindu mythological character whose body need to be split into the 2 and then thrown away so that it doesn't meet and doesn't become alive again. So a large volume AVM sometimes is likely needed to be treated in a half way. You treat half of the aneurysm first and then you treat half later on. There has been no consensus in the literature whether a dose fractionation, means treating the whole nidus in 2 to 3 fractions versus treating half of the nidus today and treating half of the nidus after 6 months, has any difference. There is a slightly higher obliteration rate with the volume fractionation, but it comes at a cost to the higher interval period bleed, and the morbidity is slightly higher with the volume fractionation in comparison to the dose fractionation. The pediatric AVM is the most prevalent cerebrovascular abnormality, and people remain skeptical with the gamma knife radiosurgery to the pediatric patients, relating to the longer life expectancy and the chances of the higher radiosensitivity. It is the leading cause of the spontaneous ICH in these patients. So this is on my experience of treating nearly around 68 pediatric patients over the course of time. Even in the literature, we find that the complete AVM obliteration is found in around 66% patients in grade 1 to 5. This is the complete cohort which they evaluated in 2019. And when they compared the different radiosurgery tools like gamma knife, cyber knife, proton beam, the maximum chances of obliteration were with the gamma knife. It's in the range of 68% compared to the proton beam, which is actually being marketed as the better and the safer option, that had an AVM obliteration only 48% in the pediatric patient compared to the 68% with the gamma knife radiosurgery. The literature has refuted about the higher radiosensitivity of the pediatric brain and the chances of the more complication. This is one patient with an 8-year-old boy, a posterior fossa AVM with a complete nidus obliteration by the end of 2 years after gamma knife radiosurgery in my series. Even the advanced stage does not appear to confer an appreciably worse AVM radiosurgery outcome. It's irrespective of the age, the radiosurgery is going to work on that. Apart from reducing the bleed rate, radiosurgery improves the seizure outcome. The seizure happens in an AVM either because of bleed or because of the steal phenomena. Once you start obliterating the AVM, the perfusion into the surrounding irritated brain starts improving, and these patients have a better seizure outcome even before the complete nidus obliteration. And in my own personal series, I found that nearly around 68% patients achieve an Angel 1 and 2 classification scheme, Angel 1 and 2 seizure outcome, the patients who presented with the seizures only. If you treat a large nidus, you remain at a risk of a residual nidus after some time, even after the end of 3 years, the 30 cc nidus may reduce to 6 cc, but it is not a cure, because in that case, the nidus is still there. So you can again go for the second round of radiosurgery by the end of 3 to 4 years with a slightly lower dose. And these patients also achieve a good AVM obliteration in around, depending in a median, 61% patients. Every treatment modality comes with its own set of complications. With the radiosurgery also it's there, but the morbidity and mortality profile is comparable, rather inferior to the surgery, especially for the complex AVMs. There has been a major argument about the radiation-induced neoplasia, and it has been proven in the Lancet that this risk is not more than 0.01 to 0.001%. So at 10 years, the risk of malignancy is not different from the general population. You may find T2 hyperintensity signal changes without any clinical correlation, without any clinical deterioration in these patients, and you just need to follow up these patients. Very rarely, which I have found in 2 or 3 patients of mine who presented with a cystic degeneration in the irradiated area. Luckily, I haven't found any radiation-induced malignancy in my so far career. Some patients had a worsened seizure when they have a T2 hyperintensity signal changes in the surrounding area, and that need to be treated with the steroids for a short duration of time. Sometimes the treatment results in massive edema. Probably when I went into the retrospect, I couldn't spare the draining vein properly in this case, and that led to a massive edema in this patient. It was a steroid-resistant edema, but you can see that the nidus got completely obliterated. I had to treat this patient with bevacizumab. Now the edema is also gone, and the patient is back to his work. Rarely, for the superficial AVMs, you may find a temporary non-cicatricial focal alopecia, but these patients regain their hair in 2 to 3 months period. That's exactly like at the site of your target. These are some representative cases which we treated with the gamma knife radiosurgery with a complete obliteration. I especially like this meta-analysis by Christian, who did on a complete AVM spectrum on a morbidity and the mortality profile in the Avm surgery, embolization, radiosurgery, and this is on a survey on the 2,452 patients. And they found that the morbidity and the mortality was least with Avm radiosurgery comparison to the any other treatment modality. So coming to the consensus, it's a multimodality treatment. It's an interdisciplinary neurovascular team where you need to sit with the neurointerventionist and radiologist to look at the complete angio architecture. There are sufficient indications to treat unruptured AVM grade 1 and 2. Even after publication of Aruba, we didn't change our policy because we knew that these patients need this any kind of a treatment over the course of their time. There are indications for treating patients with the higher grades, and that needs to be evaluated on a case-to-case basis. And while obliteration is a useful tool for evaluating the efficacy, the primary outcome is actually the functional outcome in these patients. I especially like this line as a living problem is better than a dead solution. So you treat an AVM with radiosurgery, you wait over a course of time, it gets completely obliterated. Your ego may get hurt sometimes because it's not completely obliterated in the period of time, or you may have to wait for a longer duration of time. But these patients hardly get any complication over this period. So the take-home message is that AVM treatment is complex, but there is a simple truth that gamma knife radiosurgery or SRS works. The literature so far is very heterogeneous. It's a low quality, low evidence-based data. The low-grade AVMs are best managed with the microsurgical resection. But in the high-risk lesions and the risk-averse patients, they are better suited with the SRS. SRS grade 3, 4, 5 need careful evaluation. And gamma knife with the hypofractionation and the volume fractionation, they remain the safest treatment modality for the complex AVMs. And I would like to utilize this platform to say that it's the neurosurgeons who should be expert in the radiosurgery. It's their foray. It's their knife. It's an integrated surgical knife. Along with your surgical knife, you should be good in the radiosurgery also, so that you become a hybrid person who can treat every AVM on a case-to-case basis, and you are able to take care of those patients, their outcome, complications, everything. You are able to treat that. With this, I would like to just end my talk. Thank you so much for this opportunity.
Thank you very much, Manjul, for a very, very passionate talk, well supported with the proofs, documentary proofs and various studies. And I'm very sure, though we surgeons who are purely surgeons believe more are knives, but there are many occasions like deep-seated, eloquent area AVMs. There are many AVMs, which as a surgeon, we we can't and we shouldn't really treat. And those are the areas where probably this knife, the radio, the gamma knife, is going to be very, very helpful. I'm very sure there is a lot to improve further. So probably in coming future, it will be more and more effective. Thank you very much for your talk.
Thank you, sir. Thank you.
Now, I think I would like to invite Dr. Chandra Dev Pujari, the doyen of neurosurgery as far as educative efforts are concerned. He has done a mammoth work for educating the people all over the world, and we are very proudful of him. Dr. Chandra, please.
Right. My name is always a problem. Most of the people in India know me as Shekhar, and most people abroad know me as Chandra. So I'm like a mixture of two. Similarly, I am a mixture of radiosurgeon as well as a microsurgeon. I don't have as great an experience as the two people who just spoke to you, but I have more than 100 cases of radiosurgery done personally, as well as to some extent analyzed, as well as more cases of microsurgery than radiosurgery. And I'm going to base my talk on these patients I have treated and try to get you through some of the dilemmas which have been talked about so far. So basically, I think apart from the 1990 paper, which Dr. Manjul showed us, which was probably one of the first paper on a large number of patients with natural history. This is from Toronto, which is a single center paper, which also showed that not only that the natural history was quite alarming, it also showed for the first time that the patients presenting with hemorrhage, deep venous drainage, associated aneurysms had a much bigger chance of developing repeated hemorrhages, and embolization itself was not a very preventive kind of a treatment unless the patient has undergone complete obliteration. If you look at another natural history paper, a meta-analysis of more than 9 studies, which are with more than 3,900 patients and almost 18,000 patients years of follow-up, has also shown almost similar location, that prior hemorrhage, deep venous drainage, deep location have been the most important factors, and intranidal aneurysms was added to this later on. As has been eloquently brought out by both the previous speakers, the goal of the treatment remains complete obliteration with preserved function, and you can show it like a trophy. And I think everybody is happy if the angiogram shows that you have actually done a complete job. So what are our choices? I think Aruba study has made us very, very aware that observation itself is a very good arm of treatment. Microsurgery, of course, remains the gold standard. And I think most papers agree, even if they are in interventional journals or radiosurgery journals, that microsurgery still remains the gold standard of treatment. Embolization is something which is extremely popular. I mean, I'm almost sure that no Avm will not be embolized in Europe at least. And its effect, as well as its not only its efficacy, but its role in the overall management still remains questionable, as we'll see later on. And therefore, this meta-analysis of the treatment is a very, very kind of important thing to see, that out of 137 observational studies, totaling more than 13,000 patients and 46,000 years of patient follow-up, what has been very effectively shown is that complications leading to permanent neurological deficits or death occurred in 7% patients after microsurgery, 5% after SS. I think this is a little different study than what Dr. Manjul showed you, and 6% after embolization, and successful brain Avm obliteration, which is our goal, was seen in 96% of microsurgery patient, 38% after SRS, and 13% after. So, I mean, if you take all patients, then this would be the condition. I'm sure the results in each arm will get better if we talk about selected patients. And how do we select patients remains our most important point. And you like it or not, Spetzel-Martin grade seems to be universally followed and was the first one to come up. And Spitzer, first of all, talked about this, and he actually, others showed apart from him himself, like Dr. Morgan, that they have actually shown that these factors do matter when it comes to surgical risk as well as obliteration rates. What has been more important, according to me, especially when we look at some of the extra factors and the supplementary factors, as Lawton and Young have called them, and they have given this supplementary kind of a grading system, which adds to the Spitzer-Martin system and has made it more specific. And I have not put the slides in this study, but two independent studies have shown that this has certainly improved the prediction of your treatment as well as complication rate. And as you can see, one of the important parts, apart from the eloquence and pattern and the compact nidus and previous bleeding was not taken into account in Spitzer-Martin grading, which has been found to be very important in Lawton grading, as well as age below 20 years to be favorable has also been very effectively shown in the pediatric series, which have been quoted recently in last 2 or 3 years. The other factor which probably decides our patient principles of selection is the clinical presentation with hemorrhage. And I think most patients who come with hemorrhage, microsurgery is being given serious thought of and is probably easier to accept for the patient as well. Second factor is, as we just talked about, and I think Dr. Manjul has just shown you, there is a higher risk of hemorrhage in children. There is superior outcome of surgery in children. There is radiation hazards in children, which has been now shown in 2 or 3 long studies that it is probably not such a case. The main thing that is worrisome is the recurrence after treatment, which has been shown with various treatments, and people have talked about radiosurgery therefore being superior in either upfront treatment or post surgery treatment if there is a residue. Of course, I think the other thing which matters is probably the superficial feeding artery and grade 1 to 3 cases, and they are, very good for a competent microsurgeon. This is one of the child which we treated, presented with hemiparesis, motor cortex, Avm. You can see a nice compact nidus, as typically called the inverse pyramid, which you see that the venous drainage goes up to the subependymal kind of place, and you can effectively take this out very nicely, and the patient had good outcome. This is another patient, again motor area of Avm. In fact, if your navigation can take good CT angio, you can actually delineate where is the feeding artery and where is the draining vein, and you can use it effectively during your surgery like we are doing. We have the clot is not coming up to surface, but it is just within the sulcus, and you can very nicely show that. Once you get the clot out, it becomes much easier to find the Avm, which is in the wall of the clot itself. Put a small retractor, remove the whole clot, and eventually you take out the Avm as well. As you will see, make sure there is white matter seen all over, as Dr. So a small Avm, single feeder, single draining vein, even in motor area, is worth treating by microsurgery, and you can see that it is completely resolved and the patient is cured forever. Angio architecture is being hyped about by most of the people who are in intervention, and they have said they are now trying to find the criteria where it should be used. It seems that intranidal aneurysm, single draining vein, caliber of the draining vein, and venous occlusions or venous aneurysms are important, and high flow versus low flow, as Dr. Atul Goel pointed out, is important for normal pressure perfusion breakthrough. And this is one reason why people talk about reducing the size of the aneurysm even with partial embolization. So there are so many issues, I think, which we can talk about, but I'm just taking you through at least the arguments. Why I'm stuck? My slides are not progressing. Okay, so angio-architectural features, I think there are now several studies which have shown that all the factors we talked about do matter when it comes to a question of their prognosis. I think careful study of angiogram has been very well emphasized by for both the arms of treatment by our previous speakers. And as I told you, I think a proper examination and CT angio gives you a very good idea. Apart from MR angio, depends on how you are used to it. And I think contrast angiogram probably is more important rather than just looking at time of flight images on MR angio when we are trying to do this. And this is the that patient where I showed the CT, and you have been able to, this is the AVM, and we have been able to excise it quite effectively with a good result, and the patient has had a good outcome. I'll take you through a few of the other scenarios to tell you what are the difficulties in treating these patients. So this is a 16-year-old male. About 3 or 4 years ago, he has had an episode of, about 5 months ago, sorry, he has had an episode of severe headache, nausea, vomiting, etc. And there was no focal deficit. There was no visual deficit either. And patient has had a previous history of in 2008. I think this patient I have treated about 2018, so about 10 years before, where a temporal bleed was seen. At that time, a AVM was diagnosed, but the surgeon decided only to remove the clot and not to remove the AVM because he thought it was in an eloquent area. And this patient was completely normal afterwards, and he was appearing for his 10th standard exam. When he came as to what is going to happen to me in future, I want to get rid of this AVM. And this is the AVM. This is AVM in the left eloquent area. It is situated at almost the operculum here, and they are genuinely worried about how to treat this. And I think the architecture of the AVM shows you that there is a single arterial feeder, there is a single venous drainage. So they first went to the embolization interventional person said that yes, this can probably be obliterated completely, but there is a certain chance that you may have a neurological deficit and there is a possibility of intraoperative rupture. They did not go for radiosurgery because they thought that it was probably not a good idea to go for radiation. There are several people who are still worried about radiation. And at this stage, we thought that we will treat this when they understood that there could be some possibility of neurological deficit. And this was completely treated. As you can see, we were able to excise this completely. No, I think what we did was, before we did that, we did several studies, including we did a surface rendering study, which gives you a good account of a surfacely placed AVM. 3D images are extremely good for the AVMs which are deeper. And then we did a functional MRI to show that we were probably safe to go into this area, that we were just behind the important area. And most of the eloquent cortex was above and just behind. And therefore, we went ahead and operated on this patient. Surgery was not too difficult, but what was important was not to damage. And we first make sure with ICG that where the feeding is coming from and where is the venous drainage. Once we have done that, you know, what I have tried to do is put clips on both the feeders and made sure that the AVM is completely obliterated after doing that. This made my job much easier. I knew what to excise. And on a superficial AVM, I have found that ICG can be very useful. It is useful because the sometimes it is difficult to decide which is the artery and which is the vein, except for very major venous structures. And therefore, it helps you where the blood supply comes first. So this is the deeper feeder where we put the clip first. And then we have been able to excise this completely. You can see the venous aneurysm. So small area in that sense, it is not a big surgical challenge, but to preserve the neurological function is extremely important. This boy, this is the immediate post-op angio. I get all post-op angios done before the patient is reversed from anesthesia. So they are all done in theater. Earlier, we used to do it before closure, but we have realized that it is much easier and reduces the chances of infection, etc. Once we close, we will keep the patient without clamp. Pictures are better unless you have a very good radiolucent frame, etc. So this has become our routine now. And if the angiogram is good, we will extubate the patient. If it is not, then we'll probably go back in, as I'll show you in some other cases. So this was the post-op scan, and the patient has improved remarkably well and has gone actually back to not only studies here, but study abroad. Other things which are also important is, this is an 11-year-old girl. She came, she was not talking actually when I saw her for the first time in my outpatients. She was so scared. She came with this kind of hemorrhage, and you can see that the type of AVM becomes very important. This is a perisylvian AVM. Perisylvian AVM has a lot of angiogenesis around it many a times, which is what we found. In these cases are not good for embolization. We took an opinion, and this was too big for upfront radiosurgery. So we went ahead and we took this patient up for surgery. You can see the complex AVM, and you can see the angiogenesis in the distal part of the sylvian fissure here. So this is the exposure. We tried to go through here, did not find the clot. Then we have done a temporal polectomy here to open the nidus, remove the clot completely. And then we started following these small feeders. You can see that what is more important also, I must, especially for younger audience, I would like to say that use a thicker bipolar than what you use for most of the tumor surgery. The major reason being that AVM vessels are a little difficult to coagulate. It is better to have a larger surface area for coagulation, which makes it easier for you to coagulate. Otherwise, they keep on rupturing and giving you trouble. And this went on and on for about 4 to 5 hours. And eventually we thought we have excised the whole AVM. But as I told you that after doing this, we went for an angio in theater itself. This is the last bit of AVM coming. And we checked, but as I told you that it is not very reliable to have the ICG looked good, but we wanted to go for an angio. This was the CT scan done at the end. This CT scan was actually done after the angio. I must talk about that. And the angio actually showed that there was this angiogenesis still left. And this has been later subjected to, we went back, removed rest of the clot, but we could not remove the AVM effectively except for a couple of more branches. And this patient was subjected to radiosurgery after about 3 months' time. It has been completely bare. You've been able to take all the feeders out, and the veins have actually returned back to their normal color and turgor. So this area has been treated later with gamma knife surgery. This was the follow-up. When the patient has come last, we have still not done a 2-year study, but we will usually do a 2-year study with DSA in such patients. I think talking about Aruba, I think Dr. Manjul Tripathi has already explained to you that this seriously questioned our intent to treat these patients because the treatment was found to be inferior to just observing these patients. But further studies have shown that during the same time, some centers which specialized in AVM treatment have shown better results than what were shown in Aruba, and therefore even the radiosurgery centers have shown better. Several people who are interested in radiosurgery came together and showed that the results outside the Aruba study were so much better that we should not probably follow the Aruba study. And therefore, I think we are still not sure what is the ideal treatment for grade 3 and 4 AVMs. So I'll just talk to you about a patient. This is a girl who was just out of school, and she was not sure if she wanted to go to the college or not because she was getting frequent seizures and she was told that she has a fatal disease. This is the MRI she came with, and we decided to go for an angio. She also came with this CT angio, which shows you a bad angio architecture. We discussed all the features, and she was told that it is in such an area that she will remain hemiplegic the rest of her life if she goes for surgery, and it is too big for radio surgery. And she literally stopped going to school. She stopped appearing for any exams to go to college in spite of being a bright girl in her school. And she actually did not speak to me when I first examined her, but her father and mother decided that they wanted surgery if it can be done. And looking at the angio architecture, the fact that we had a superficial venous drainage and we had only 1 or 2 feeders which were coming from MCA, I said we should go ahead for surgery. And we did go ahead for surgery. For some reason, I am not able to show you the operative picture, but you can see that the whole AVM has been completely excised, and this girl not only woke up intact, she started going to college a year later and have graduated now after about 3 years or so. Embolization, I think both the previous speakers have already talked about limitation of embolizations, but I think if you have AV fistula, it remains an effective treatment, like one of the cases Dr. Goel showed earlier. I think intranidal aneurysm, if the patient, if we can wait, if there is no major clot, and if the intranidal nidal aneurysm can be embolized, maybe it is good for surgery. The major problem we had in initial part of our career was the embolization was done with glue, and it used to become so hard that we could not actually handle this while excising this AVM. Today with Onyx, it is not so bad, though it sparks a lot on bipolar cautery. It is easier to manage Onyx embolized AVM today than the earlier glue embolized aneurysm. My main indication today is if there is a deep feeding artery, if there is more than 2 feeders, and if one of them is a very deep feeder, I would prefer that that feeder is at least taken away so that I can probably use the approachable feeding arteries much easier, and occasionally it is to reduce bleeding, though it is not always. And another important study why everybody is not so friendly except for our European colleagues, that curative embolization is seen hardly in 5%. Now this paper was in 1995. If you look at the newer papers, I think they talk about 28 to 30%, but nobody has talked about figures like microsurgery or radiosurgery for AVM obliteration with embolization, and therefore it remains an important preoperative method. It also, we have talked about the paper earlier, there are several other papers which talk about risk of embolization, and one of the risks of embolization which has become very important to understand, that the AVM recurrence has been found to be high even after microsurgical obliteration if the patient has been previously embolized, and similar results have been shown even in SRS as Manjul has shown. But in an AVM like this, where the vessels are hypertrophied, this patient actually came to me after embolization when AVM could not be completely obliterated, and I was happy that some amount of nidus had been taken care of, and it became easier for me to operate on this patient. As you can see, this large AVM could be very effectively treated without too much of bleeding. You can identify one feeder after the other. And you can then eventually excise this whole AVM. And embolization has helped me because I could do this surgery virtually bloodless. Radiosurgery, I would not talk too much. Manjul has spoken about, but I'll probably show you a couple of illustrative cases. I have used it predominantly for eloquent area. Very way back in 90s, maybe 98 or 99, I first saw a boy. This was the boy who presented with speech arrest and frequent seizures, 3 or 4 seizures a day. His life had become miserable. I did not want to operate on this patient, and I subjected him to gamma knife surgery. And this is one of my first AVM cases. And this actually obliterated a 1 year angiogram. And this patient has remained well since, and with the good seizure control as well. Another patient, very remarkable case. One patient I have treated in my early part of my career with a basal ganglia. And I think this remains an important consideration. And over 2 years, the obliteration, complete obliteration. And this boy has also developed very well. He was 8 years when he was treated. And now he's almost 26 years old and leading a normal life. I think there are several SRS series reviewed, but I would not talk about it. I think what is important is pediatric versus adult brain malformation. A multi-center study has shown that the results are almost similar, and age seems to be a poor predictor of AVM outcomes. I think both are treated equally well. I think radiosurgery outcomes in unruptured AVMs have also very similar to ruptured AVMs, and as good as 78% obliteration rate in properly selected patients have been shown by the Pittsburgh group. This was one of the patients which I thought I could not have treated otherwise. This is a completely intrinsic AVM, brainstem AVM, and and there is an intranidal aneurysm as well. The radiologist said that if you by that time we realized that embolization can create problems with the target mapping in gamma knife. So we treated this patient with a peripheral dose of only 15 gray, because in brainstem you are constrained at 30% actually. And this AVM gradually showed obliteration over next 4 or 5 years. However, this patient, one of my first patients, when I saw this severe radiation edema, it responded fortunately to steroids, and this is the last 9-year follow-up, which shows that there are very few, but on angiogram, there is no venous drainage seen. So we are quite happy with this. Now, what about multimodal series of embolization? The embolization followed by SRS has not been very popular. And I'll just show you a couple of cases before I stop. So grade 4 and 5, I think patients require a multimodality treatment, except if they go to Dr. Goel. I'm sure he can treat them. He has shown us several cases today, but I'm scared. This is one patient who came to me, 13-year-old boy. He came from somewhere in South, and he said that they are not ready to undergo any surgery because this is again a motor premotor kind of a AVM, complex AVM with intranidal aneurysm, venous varicosity, etc. We measured actually that this AVM was about 10 cubic centimeters, and we decided they wanted radiosurgery as the primary treatment. So we talked about the fact that there may be the obliteration rate may not be as good as expected, and we could treat with 80 gray at this. AVM started reducing in size over the next 6 months, 12 months, and patient remained asymptomatic for almost 2 years, and then was almost lost to follow till one day they came back around 3 years after the treatment, when the patient developed repeated seizures and started developing hemiparesis. This was you can see that the character of AVM has changed. The varicosity has become much bigger, and the nidus has become actually smaller. This was the nidus which was seen, and at this stage, I decided to operate on this patient, which is what I offered them, and they agreed. And this AVM, once I could identify the proper feeder, we went ahead and removed this AVM completely. Okay, I'll move further. Sorry. Can't rush, I suppose. So we could remove this completely without causing any neurological deficit. 3 minutes before I close.
You,
Can you hear me?
yes, we
Yeah.
can hear you. You may have to reload that.
Yeah, that's what I'm
Yeah.
closing it.
Yeah, close it and open it up again.
Oh. No, okay. Sorry, guys.
Now we have voice.
Now you can hear me also as well?
We can hear it, but we
Yeah,
can't see
yeah.
it. We can't see it.
You can't see it. Okay,
No,
just give me a
not-
minute.
You need to open up the file.
Now?
Not yet. Oh, there we go. There we go.
Okay. So this was the immediate post-op angiogram, which shows a complete occlusion, and this boy actually not improved neurologically over the next 3 months. His seizures have also stopped. This is about 4 years now after his surgery. I think recurrent cerebral arteriovenous malformations, Dr. Manjul mentioned about this, and this is one of the reasons, especially in pediatric patients, there is about, some people have described up to 6 to 7% recurrence rate. And delayed imaging studies are therefore required in these children. And one of the reasons is the active angiogenesis mediated by humoral factors. And people feel that if you treat with radiosurgery, it probably would be much less. This is a systematic review which has come in 2018, which also talks about the same with a bigger case series of about 73 patients. This is another one which also gives you the same picture with, I think, even more patients now. So AVM recurrence in pediatric patients must be looked for. And I think gamma knife surgery is a good treatment to give because of this reason. I will just show you one. This boy now eventually when I treated was 30 years, but at the age of 14 years, this boy was treated with one shot of embolization. And, you know, on the post embolization, you could just see something like this angiogenesis. So correctly, it was subjected to SRS, but at another center, not at our center. And after SRS, the boy remained well for almost 6 years. And this was the CT scan. The patient did have post-embolization yearly follow-up. And on one of the follow-ups, the angiogenesis seemed to have increased. And at this stage, the patient got SRS done. And 3 years after SRS, this boy came with progressive hemiparesis. And that is the time when I saw this boy for the first time. By this time, he was about 26 years. This cyst had developed with right-sided hemiparesis and speech difficulty. We drained the cyst 3 or 4 times, but over a year, it just kept on coming back again. And therefore, I was asked if I could excise this cyst. Before excision, I thought we must do at least a CT angio. I found this, and therefore, I went ahead and asked for an angiogram. The angiogram shows actually that there is a residual AVM still. So I am just showing this to show that in spite of SRS, you can still probably have. And in this patient, you can say that maybe because he was embolized further, maybe the target wasn't adequate. But this patient therefore required another surgery for excision of residual AVM with cyst excision. And thereafter, this boy has remained well. I'll end up this with a 13-year-old girl. She is a doctor's child who came with hemiparesis after the first bleed. And this was actually embolized 3 times. After embolization 3 times, she was subjected to radiosurgery. And after radiosurgery, it continued to fill up. And at about 4 years after the initial treatment, they decided to come for surgery. And we excised this completely. The girl became completely hemiplegic after the surgery, which was explained to the parents who were both doctors, or I think one was doctor and one was, mother was the nurse. And 6 months later, this girl came walking and could use even her right hand, and is now studying abroad. So I think the lessons learned are that the patient understand both the natural history. You have to spend a lot of time counseling these patients. With talking about treatment related risks and benefits, yes, you should be confident. If you can remove this, you must do microsurgery. If you cannot, then we have to talk to the multidisciplinary team. And the anxiety and uncertainty wrought by living with an untreated AVM is a significant burden to the children as well as their families. And a substantial upfront procedural risk may be worthwhile for many patients who desire permanent AVM obliteration. Thank you.
Thank you, Dr. Dev Pujari, for sharing this hybrid experience of yours. And I personally believe that a person who does surgery, microsurgery, as well as the radiotherapy is a person to he can take a good balance, better balanced decision, because he remains unbiased. So I think probably this is what Manjul also said. I think we need a sort of a hybrid neurosurgeons who do both. So I think that's a good experience shared by you. Thank you very much for your talk.
Thanks.
Now, may I invite, I can't see him. Is Aip Charian here around?
Yes, Aip is very much here. You unmute yourself, Aip.
I'm here.
Aip, hi, Aip.
Hello.
Dr. Aip Charian is a director of Institute of Neurosciences at Krishna Institute of Neurosciences, Karad, India. And he has been championing about cystonostomy for TBI, traumatic brain injuries, very passionately. And by that, he has tried to bring microneurosurgery into trauma in head injuries. But here he's on a different front now. And I think, I don't know what he has in store for us as far as AVM is concerned. Go ahead, please.
Yeah, so as I was, thank you very much, Dr. Lokendra Singh. Thank you, sir. And I was watching with great interest Dr. Manjul, and then Professor Goyal and Professor Dev Pujari. I don't think I have anything else much to say, because if I say any more on AVMs, it'll be, become redundant. For the young neurosurgeons, I can tell you a few lessons before I move on to something which is quite different. Now, for AVMs, can I share the screen? Yes. So for AVMs, we, as Dr. Goyal had mentioned, we really don't follow the Spätzle-Martin for many years. I don't know whether it helps or not, but what we do is we divide them into diffuse and compact niduses. So the way that I'll tell you will be very simple. If it is a compact nidus, we look at the location, and on the location we know it's not very difficult, extremely difficult. Sometimes if it's a compact nidus, the case would be impossible, but then that is very rare. But when it's a diffuse nidus, this is a terrible thing to do. We've got into trouble doing those, and the diffuse nidus are what I would rather hand it over to Manju. And another thing I would want to tell the young neurosurgeons is the AVM is a surgery where it's like a very high definition painting. So you need to spend a lot of time dissecting the vessels out. So the veins, the arteries, everything has to be, you have to take a lot of time under very high magnification. You have to dissect it. And then when you're going around the nidus, what we do, I don't know if Professor Goyal and Dr. Dipachari will agree to it, but we keep about a millimeter of brain around the nidus, so that this is the area which we feel is gliotic, and this is what can undergo later on the NPPB. So it's always better that you keep that 1 millimeter, you don't get onto the top of the nidus, but you keep that brain around the nidus. And this way, if it's a compact nidus, usually the blood flow is, for the last, this was done in 2016. This is a grade 5 AVM. For the last at least 4 to 5 years, we've never had to transfuse in an AVM. That's because we select our patients and we keep these principles. Now, rather than an AVM, I would tell you something new. I would take about 10 minutes. It's a Sunday evening, and all of us wouldn't want to be tied down on a Sunday evening. I'm going to show you some interesting things. Number one, you see this in my hand? I got to probably take the blur off. You can see this in my hand. Do you know what this is? This is an electric toothbrush. Okay, it's an electric toothbrush. It's a company, is something called Oracura. And we have been testing this for over 4 months. And do you know what it has? It has a piezoelectric crystal at the tip, battery-driven piezoelectric crystal at the tip. Okay, and the frequency is around 30 hertz. So the beauty about it is about $100, and it is the same principle as that of a accuser. So you attach an ice cream scoop. We 3D printed an ice cream scoop onto the tip. We've given this project to the medical students, and we're now testing it. And in cadavers, the brain tissue, it's so easily coming out. Okay, we believe that if we can change the circuit or change the piezoelectric crystal, we may be able to make a accuser which is hardly maybe $200, $300. So, and the way it works, this is the way it works. And if you're able to, right now we've tested it on the bone because it's 30 hertz, because bone needs less than 25 hertz to be taken out. So we were hoping for it to be a substitute for a drill, but it was not to be. But then soft tissue tumors as well as glial tumors, I believe this is a fantastic alternative. It is very small. The attachment can be made as long as you want, and it can be made bioneted. So this is what we are looking for. And this battery lasts for 8 hours easily. So it's like a portable accuser, exactly the same action as the accuser. And it's we cannot have a suction attached to it, of course, but we have a suction in the other hand. This will break the tissue as easily and as effectively as accuser does. So this is one thing I wanted to show you. And another, let me show you another thing. Can you see this screen?
Yes.
Yeah, so this is an exoscope that we've been experimenting with for the last 4 to 5 months. So we did that. We first experimented with papayas and pumpkins, and then went on to the cadaver lab. We did cadaver dissections. We did anastomosis, and then we started doing cases. So we started off with some few ST grafts, STMCs, and ST grafts, and so on. And it's truly amazing. I believe this is the future of neurosurgery, because we've been operating. We have a Kinevo and with the exoscope function, but this is far better. Why? Because this we have taking an ST graft. So it's far better because you don't have to be attached to the microscope at all. You can sit, you can put the screen where you want, and of course this is the Kinebo. And I'm going to show you some more of these exoscopes pictures. So that's an exoscope. This is my consultant doing it. So I had a learning curve for almost 2 to 3 months. And after that, this is my consultant. Yesterday, he did a large tumor attached to the transverse sinus and the tent. So he was doing it. It was pretty comfortable for him as well. So he's only 2 years as a neurosurgeon, and he was able to do it. So he's not a lot exposed to the microscope, so he doesn't have the difficulty to shift from the microscope to the exoscope. That's usually the difficulty. So I had quite a lot of difficulty because the ergonomics was not very easy for me. But the young boys, it is much easier for them. So much easier than a microscope. So this is the picture. The zoom, the combined zoom is near 100, which is just amazing. We have a 55-inch screen, and on that screen we have this combined magnification of over 100. So all the vascular procedures and the stereo depth is just out of the world. I mean, I have the Kinebo, and I've been using the Pentero for many years, and I can tell you one thing, that the stereo depth in this thing is just out of the world. So it looks a bit artificial, but then you are able to, at very high magnifications, the 3D perception is almost, it's like hyper 3D perception. So it's fantastic in that way. So plus, you can go to the surgeon's screen and tell him, okay, this is what you want to do. It's in 3D. It's like the surgeon is seeing here, and you can go to this place. And we are trying to figure out where I can do it remote as well, because whether I can use a mouse pointer on that. So, but in the theater, I can go to this place and tell him, hey, listen, this is the place I want coagulated, or this is the place I want it to be taken out. And now this is the ergonomics. You can put it on any side. I mean, it has got a robotic arm, so it can extend to any way. And there is this point lock function. Once you're into the cavity, just like the Kinebo, this has a point lock function where you point lock it. It will be focused on that point, and only the scope is going to move this way, that way, whichever way you want it. So you can see all the angles around. And you just need a little bit of a touch on the foot pedal, and you can see all the angles around. And and if you want the scope to move out of somewhere, the point of focus will still be there. And this way, this is an amazing function. Kinebo also has it, but this one, I found it much better. And you see, everybody who's operating gets the 3D view. And so the assistant doesn't have to hang around to anything. I mean, she or he can just assist with so much less hassle. Okay, you don't have to be a gymnast to assist. Some of the cases that we do with the microscope, the assistant gets a very raw deal, we know. So these are some of the pictures in the depth. And plus, now another thing that I want to introduce you to is this is the robotic endoscopic holding arm. So we designed this from Franca Amica. Now, Franca Amica, their advertisement starts with the robot holds a pin and a balloon is kept. So the robot comes, before the balloon pops, the robot stops. So that is the kind of pressure sensitivity that these robots have. One of the greatest problems with robots is you're always worried whether the robot will knock you over. So, but then this has, if there's any pressure, you can actually program the pressure. You can program the pressure to such an extent that you can make sure that the robot stops when it encounters any kind of resistance. So what this does is, these are torque motors. These are torque motors with over 7 DOF. So I can take it anywhere I want, and the endoscope will be held in this part. And once the endoscope is held, I release this button, nothing is going to collapse. I also used to have the poinsettia arm. The poinsettia arm, the Mitaka poinsettia arm I used to have. I mean, and I used to use it for intraventricular procedures as well as skull-based procedures. But I did not like it because the moment you released it, it would collapse and then you'll have to support it. But this one, these are torque motors. So they will stay wherever they are and they are ultra steady and it will not take any effort. You just have to release the lock and the endoscope can be floated around wherever you want it and positioned. And then after that, with the NeuroPilot, the Escolapse NeuroPilot, you can position it anywhere you want. So this is the robotic arm. I can probably show you a video of how it works.
Wonderful innovations.
Yeah, so these are what I wanted to show you. We have many more things in the pipeline. We wanted to make sure that we've started this Escolap Academy lab so that we have injected cadavers. Dr. Tamerlan Konev, who is with us, he does this injected cadavers. The Escolap Academy does all these skull-based courses almost every month. This 21-22 we'll have another skull-based anterolateral as well as lateral skull-based workshop over 2 days. And here we're trying to use these devices in terms of visualization, as well as tumor fragmentation, as well as retraction. In every way, we're trying to change things. And there's no fun doing the same things all over again. So we're trying to change things so that the new technology that is already available for us for 10, 20 years can be brought to neurosurgery. And our lives can be a bit more better. So the patients' lives as well as our lives can be a bit more better. That's what we're trying. And rather than writing papers, I would exhort all the young neurosurgeons to get into microneurosurgery, innovate, and improve. Thank you very much.
Any experience with AVM surgery with Exoscope?
No, not yet. No, not yet. So but we are doing one on Thursday. This coming Thursday, we're doing an AVM with the Exoscope. This is a grade 2 AVM. And I can tell you by the next grand rounds, I can show you the AVM pictures, AVM videos as well.
Worth watching.
Thank you very much, Dr. Cherian. It was really, really wonderful. Actually, very refreshing and, something different, out of box. I think this is what is needed because we sometimes are with the blinkers and we don't see around. So I think this will bring freshness. And I'm very sure you will, in coming 2 years, you will probably introduce more and more new things like this. Thank you very much for this. You took a detour, but that was a very, very useful detour.
Thank you. Thank you so much.
Hi, John. Now it's up to you.
Okay, thank you very much, all the speakers. Great conference. So I'd just like to make a quick announcement. We're going to have a Gamma Knife neurosurgery webinar in a month because I was looking for online webinars on Gamma Knife. I couldn't find any. So I think we need some updates, and Chandra has already volunteered to talk, and anyone else who's interested in participating, just put your name in the chat box. So, okay. I guess we'll see you guys in 2 weeks.
Thank you. Thanks a lot.
Thanks, everybody.
Thank you, John. Thank you, everybody. Bye-bye. And
Thank you, Dr. John.
I think.
Let me put it back on. Okay, I'll just have to edit that out. Okay, continue on.
No, maybe
I'm recording again.
One comment from all the panelists, maybe.
Yeah, actually, let me ask first. let me take the lead. Question is to Atul, of course, because Atul has his own dynamic sort of a classification in his working. And with other classifications, we know there's a cutoff point that after this, for example, SM classification, Spazler Martin, you know that beyond 6, you will not do it. Sort of that sort of stop cut points are there. Atul, what do you do? How do you decide that you are not going to operate this case? What are your markers?
Yeah. One is, you know what, as I mentioned to you, it is absolutely important for the surgeon to realize that there is a safety in resection of this AVM. I can do it safely and it is possible to. So we have to keep the margin, safety first and resection next. So if we are able to have that vision by virtue of the nature of AVM, location of AVM, the adjoining area, whenever a surgeon is operating on a complex AVM, he's worried. He's worried about 2 or 3 things. One is he should not take a normal vessel and, have a bad issue with the patient. That is one issue. Second thing is he's worried that there should not be an uncontrollable hemorrhage during the operation and there is blood all over the place. He's worried about that. And he's worried that, he may not be able to get the plane and get over the AVM. So he's worried. He's a worried man before the AVM is being handled. So he should know exactly what will be the situation during operation, whether he'll be. So there are various issues, the nature of AVM, location, the types of venous drainage, the types of arterial feeders, the location is the main issue, the size is another issue, and various other things. So when he sees the AVM, he should have that kind of vision that yes, it is possible, or no, it is not possible, or it is extremely risky to do this thing. So when it is extremely risky, it is better to avoid, because many of these patients are not very symptomatic. They have hardly any symptoms. Some people come with bleed, but others come with minor symptoms.
Absolutely.
Like convulsion, like headache, like giddiness. So the other symptoms are minor, except for patients who come unconscious and with bleed. So it is a very, very tricky Lokendra, as you can imagine, as you know, of course.
There is only one problem with this. For example, if somebody wants to follow your way of surgery, then it is so subjective that he doesn't know what to follow, because he has to be Atul Goyal then. I mean,
we have to, in our life of neurosurgery, one is we have to know our own self. That is that, Lokendra, as I said, AVM surgery is highly anatomical, AVM surgery is highly technical, and AVM surgery is highly philosophical. And that philosophy is to analyze our own self. And if we know our own self, yes or no, and that is, there can be no shade of any ego in that. There can be no shade of any pride in that. There is no shade of any hyper confidence in that. There is a shade of realism, realistic, and understanding your own self. And that is the thing. And if you are having a feeling, yes, it is quite heavily risky, it is better to not venture into it. And then you can think of, now I'm thinking of in this kind of situation where partial embolization can be a possibility, where there's little bit radiation can be a possibility, at least making a very nasty AVM into a controllable AVM. So that I am wondering whether it is possible or not. I have not really gone into it, but that may be a possibility.
Thank you, Atul. Thank you very much. Others, please. Any questions from other panelists?
I'll just make one comment. What I've said is that many people have said this. In fact, Ghaus Malik, who's one of my teachers for AVM surgery, he always used to say that you should take out AVM like a meningioma. And, you should try to be, if you're all around it, you are not likely to come into any problem. And therefore, if you have to take out a little bit of brain around it, it is okay. I think this is fine in areas where you can take out that 1 millimeter around. The problem comes in eloquent areas. And there, I think your plane of dissection becomes important. So I think the same analogy can probably still go in a compact nidus AVM, but you need to be close to the AVM rather than, getting into the brain. Getting into the brain is very, very important in probably a large AVM in a non-eloquent area, because then you don't encounter any bleeding at all. So it's a very good strategy when you can do it.
Yeah, so yeah, I mean, I would like to add, I mean, yes, I mean, I thank you for this, but I would like to add that when you are on the AVM nidus, the vessels are much more friable. The vessels that are feeding are much more friable. They are, I use a 2 millimeter bipolar. I mean, I use a micro bipolar in one hand. We always keep 3 bipolars. So always non-stick. And the 2 millimeter bipolar is for these vessels which are really friable. They are not amenable. I mean, I'm sure you would know, all the surgeons here would know that it is not like the normal vessels. They are friable. You end up charring a lot of brain more than that you would want to. And if you go a very little distance away from the AVM into the brain, these vessels are amenable to microbipolar. So this is the difference that I found. So that is why I go ahead, and there will be a layer of whitishness over my AVMs. But it is, as Dr. Chandrasekhar Dipujari said, I mean, it is never that I get into the brain. I always, whenever I see the AVM surface, I get back to the brain. And then these vessels.
Malice made it a point to talk about this 2 millimeter. I mean, very few people of this generation must have heard his talks, but he makes a big point about this 2 millimeter forceps to be used for AVM surgery.
Yeah, so that is extremely useful. That is extremely useful. This was something that I picked up when you have visited our center. And I mean, before that, we were using microbipolar, and we were very, very frustrated. And we were using non-stick gold 0.4 and 0.6 millimeters up to 1 millimeter. But you have said get the 2 millimeter, and that after that, life has been easy, I can say.
But when I was with Professor Yazergil as a fellow, he always used to follow this, that he will be just in the gliotic zone. Because just a very thin gliotic, and I also follow it. I just go into that gliotic zone, which is just there outside the nidus, keep on working in that. And with the gliotic tissue, when you burn it with 2 millimeter bipolar, those vessels also get burnt nicely. They don't get charred that much. The vessels, yes, they don't rupture that easily then. They have a coating of gliosis. So yes, I think absolutely. But as far as eloquent area is concerned, any surgery in eloquent AVMs, eloquent area AVMs is extremely, we are frightened to operate in that area. And that's why probably the radiosurgery is gaining upper hand in those areas. Because for surgery, when there are deep venous drainage is there, or they are very thalamic or brainstem, all those what Atul has also shown, those are extremely dangerous areas for any sort of a surgery with any sort of expertise. So I think
in Nepal, one of the things that we found that we never got any unruptured AVMs. So we always got only ruptured AVMs. And if it's eloquent area, they would probably, patient will be coming with a hemiparesis or a hemiplegia. So it is not that unlike unlike in India, unlike in big cities like Mumbai, we don't get unruptured AVMs. We always got, I mean, there would be a 18-year-old guy with a bleed in the emergency. We know that it's an AVM. So we first evacuate the hematoma, and in the same admission, we go ahead and do a DSA. And in 1 week to 2 weeks later, we go ahead and take out the AVM. So deficit as such was, a patient walking to you and then patient going back with the hemiplegia was never a problem with me, because most of these AVMs that I see was ruptured. Sometimes, in fact, I remember sometimes we got unruptured AVMs and it was impossible to counsel them to get operated because with the risks associated, they would never choose to. So this was one of the things. And another, sometimes I had patients who had an AVM bleed 6 to 7 months before, had the hemiparesis. They had a eloquent area AVM. Hemiparesis improved. They came, we operated, then there was a hemiparesis again. And then we found out that the patient improves after that. So it is not as if, it is not like they don't improve at all after the surgery. So they do generally improve way much better than, this is what I have found. I don't know if you would want to comment on it.
May I have a comment on this, sir?
Yes, yes.
Because so most of these patients actually, which come to us, are nearly in 30 to 40% patients, they do not come with a clinically symptomatic bleed, because these patients get referred to you from the neurologist because of seizures or just as an incidental detection at some point of time. So we are never sure in which part of the natural history of the disease I am evaluating that patient. So when you are evaluating these patients, you need to especially look at the diffusion weighted images, SWI images, because sometimes it's a clinically asymptomatic bleed. You get an evidence that it has already bled without any clinical correlation into that. If you find that that patient is at a slightly higher risk of a future bleed in comparison to a person who has no evidence, no radiological evidence of a prior bleed. Apart from it, you need to look at the perfusion scans of these patients, because the patients who presents with the seizures, they have a hypoperfusion because of that steel in that area. So if you have an intention to treat for, consider it likely to be an epilepsy surgery. So if you have an intention to treat on that line, you need to evaluate patients on perfusion scans. You need to evaluate patients on SWI, DWI to find an asymptomatic microbleed. And then you are in a better position to guide them for whatever the treatment modality you choose for them.
I remember one of my most terrible AVMs, which didn't end up so badly, was a CP angle large AVM. It was in the cistern. I remember having taken up, probably I took off, I don't know whether it was an ICA, but I think I took a pretty large vessel, which I thought was the ICA, and I thought the patient is going to have a pretty bad deficit. And I took it quite close to the basilar. So I was dead scared that the patient will wake up with a very bad deficit. It was crazy. Maybe I was very lucky. The patient did not have the kind of deficit that I feared. Of course, she had some ataxia, and which later on improved, but it was much better. So I think luck favors the brave, and this is like really jumping off a cliff. The AVM surgery, the good thing about the AVM surgery is once you made a decision and once you made the incision and started the AVM surgery, you cannot stop it in between. You cannot do a partial resection. So
okay, so let me make few last comments, and then we have to wrap it up. Basically, AVM surgery is the only proven treatment, to say the least. But the thing is, surgery is difficult and surgery has to be done properly, and there is no way you can back out once you have started. So you have to learn and develop, and it is possible. You know, it looks more difficult, it looks more dangerous when you look at the angiogram, but when you actually have the courage to enter into the field, you find your way, you find your pathway and find your channels, and ultimately you can, do a good job. The question is, if you are not sure, it is better to avoid it and not enter into this jungle of blood vessels where you can yourself get lost. So at that point of time, you think of alternative options, which may be in your own interest and in the interest of the patient. However, AVM surgery is a beautiful operation, has to be learned over a period of time. And I wish and I hope the young neurosurgeons in the audience will not leave this option and will enter and take this option. And my best wishes to all of you. Lokendra, any last comment from you, my dear Lokendra?
Yeah, I was just because we have, Aip is a very, very innovative person. I was just a very wild thought came to my mind right now. Can we use, the dry carbon dioxide on the tip of some instrument and just touch the blood vessels and just they get frozen. They are frozen, but sometimes you feel that, oh God, I've done something wrong. Let it again warm up. So it's a reversible sort of a thing. But otherwise, if you want to, you just freeze it and cut it. Is it possible? I don't know. Very wild thought.
Lokendra, just
Wow.
wrap it up now.
Wow,
I
fantastic.
will work on that.
No,
will
wow,
work
that's
on
a
that.
fantastic thought. I have never thought about this. Maybe if we can get the dry ice to form on a vessel, and it can stop the bleeding. Theoretically, it can stop the bleeding. But what will happen when the vessels, because the blood is at almost 37 degrees. So you have continuous flow of, you have all around, you have 37 degrees. So will you warm up and it will unfreeze it is the question, because if you are trying to do it on a small scale. So, but yes, it's a fantastic thought, and I'm happy that kind of a thought came. And let me try this out, and let me see if there is any way of trying it out. And let me think about it, and I'll get back to you.
Okay, thank you. Okay, guys, I think, John, can we wrap it up, please?
Okay, very good. Thanks, everyone, once again.
Thank you, and thank you for your
Thank you so
patience.
much.
I'm sorry, extremely sorry. I just cut it short. And
Thank you. Thank you very much. And
Thank you, sir.
Thanks, John.
we'll
Thanks,
meet again
Lokendra.
after 2 weeks.
Okay, 2 weeks.
Thank you, sir.
See you, everybody.